Let's talk about triple assessment in a patient with a breast lump. Now, you know, whenever a patient comes with a breast lump, we have to do three things. Okay, three things are to be done, and these three things would be a history and physical examination. That is the first thing which you do. Then you have radiological investigations, and finally histopathological investigations. So, very important that you remember this, that radiological investigations will always come before histopathological investigations, right? This is a common mistake which students make in the exam, that when they are asked which is the first investigation, they write FNAC. That is wrong. A radiological investigation always has to be done before a histopathological investigation. And why? Number one reason why you need to do radiological investigations, so that you can assess both the breasts. And secondly, if you do a needle test or a biopsy, that can induce some amount of hemorrhage, and that can alter the radiological findings later. Right? So these are the two reasons why radiological tests should be done beforehand. Now, another important aspect is that if the patient is less than 40 years of age or more than 40 years of age, what will be your first radiological investigation? If the patient is less than 40 years, we get an ultrasound done. Whereas if the patient is more than 40 years, we get a mammography done. Why is this difference there? So the reason behind this is that in young patients, there is dense breast tissue, and mammography is not sensitive in dense breast tissue. Just to highlight this point, I want you to have a look at these 4 mammography images. Okay. Now, you can see that this is the mammogram of a patient who has very dense breasts, right? So there is dense breast. You can see that it has a whitish picture. Now, imagine if there was a white lump in a white background. You can't make out a white lump in a white background, which is why mammography is not sensitive in young patients. But as the patient ages, you can see, look at this image, the breast has become fatty, right? And you can see that fatty breast has a black outline, and it is easy to pick up a white lump against a black background. So which is why mammography is sensitive only after 40 years of age. It's not very sensitive in young patients. So young patients, ultrasound, more than 40, mammography. There is another investigation known as MRI. We'll talk about these radiological investigations in detail. Histopathological investigations, you can have FNAC, true cut or core needle biopsy, and excisional biopsy. Again, we'll talk about these 3 in detail as well. Right, so let's talk about the radiological investigations. Let's talk about mammography in some detail. Now, mammography is nothing but an X-ray of the breast, right? It is a form of contact imaging, right? Where the breast is compressed between 2 plates and you get an image of the breast. So, for mammography, the amount of radiation exposure is 0.1 to 0.2 centigrays. This question has been asked many times in the exam. And whenever we do a mammography, 2 views are taken. We take a craniocaudal and a mediolateral oblique. So I'll repeat again, craniocaudal, that is when you compress the breast from above and below, and mediolateral oblique, which is when you compress the breast from side to side. So these two views are taken whenever we do a mammogram. Now, mammography can either be a screening mammography or it can be a diagnostic mammography. So this is again something which students tend to forget. They always think that mammography is only a screening modality. That's not true. So you can either have a diagnostic or a screening mammography. Now, if you talk about screening mammography, this is the best screening investigation in breast cancer. Mammography is the best screening investigation for breast cancer, and the latest guidelines recommend that annual mammography should be done. Annual mammography should be done starting from 45 years of age. Okay, so these are the latest guidelines. Earlier it was 40 years. It has been changed to 45 years now. Okay. Right. So whenever we do a mammography, you get an image, and how do you report that image is very important. So the reporting of the image is in the form of a BI-RADS score, right? Of a BI-RADS score. BI-RADS stands for breast imaging, reporting, and data systems. Breast imaging, reporting, and data systems, right? So what is the need of having this BI-RADS score? The reason why we have this BI-RADS score is so that there is standardized reporting. Okay, whether you do a mammogram in Delhi or you do a mammogram in New York, if there is a BI-RADS score associated with it, you know what the lump looks like and how to take action on that lump, right? So it is for standardized reporting. And BI-RADS became so popular that now even for other organs you have this score like TI-RADS, LI-RADS, and PI-RADS. So you have thyroid imaging, reporting and data systems, liver imaging, reporting and data systems, and prostate imaging, reporting and data systems. Okay. Now, this table is very important for your exam. A lot of questions have been asked in the exam regarding this. So let's just go over it, and I'll tell you some scenarios which you need to know. So first is BI-RADS 0. BI-RADS 0 is an incomplete investigation, right? So let's write here incomplete investigation. Okay, so what happens, a young patient, say a 30-year-old patient, goes to a doctor, and by mistake the doctor sends her for a mammogram. But we've already discussed that in a young patient, if you do a mammogram, you will get this dense breast tissue. You'll get everything would be white. So even if the surgeon is feeling a lump in the breast, the radiologist will not see anything on the mammogram. And the radiologist is going to say that the surgeon has gone bonkers. There's no lump in the breast. Fine. So the radiologist will write that it is BI-RADS 0 or incomplete. And the intervention is that you require some additional imaging tests. So in this case, it can either be an ultrasound or an MRI. Additional testing would be required. BI-RADS 1 is negative. That means everything is normal. There's nothing wrong in the mammogram or the ultrasound. Okay. So you call the patient back after 1 year. Routine screening means you call the patient back after 1 year and the likelihood of cancer is 0. BI-RADS 2 is a benign lesion. You can say a fibroadenoma. Fine. So on a mammogram or ultrasound, if there is a BI-RADS 2, it's probably a fibroadenoma. And again, routine screening, that is after 1 year, the likelihood of cancer is essentially 0. BI-RADS 3, this is where things start to get a bit interesting. BI-RADS 3 is probably benign, right? Now, if you get a BI-RADS 3, the important thing is you need to call the patient after 6 months. So short-term follow-up, and you repeat the imaging after 6 months. And the risk of malignancy is less than 2%. BI-RADS 4 is a suspicious lesion, and all suspicious lesions require a biopsy. BI-RADS 4 has been further subdivided into 4A, 4B, and 4C. 4A is when the risk of malignancy is more than 2% but less than 10%. 4B is when it's more than 10%, less than 50%. And 4C is when it's more than 50% but less than 95%. All three of them require a biopsy. BI-RADS 5 is highly suggestive of malignancy, and these patients also require a biopsy. And BI-RADS 6 is a biopsy-proven malignancy. Okay? So these are the BI-RADS categories, and I also want you to remember that BI-RADS is for mammogram and ultrasound both, not only for mammogram. Okay, so we were talking about mammography, and one more thing which I want you to know is that the latest type of mammography is known as tomosynthesis, and this is also known as 3D mammography, right? So a lot of trials are being done on tomosynthesis or 3D mammography to assess its role for the diagnosis of breast lesions. The other imaging modality is ultrasound. Now, we've already discussed one indication that this will be the first imaging test in a lady who's less than 40 years of age. Okay. What are the other advantages of an ultrasound? It is radiation free. Because it is radiation free, that is why it is useful in pregnant patients. Another advantage of an ultrasound is that this is the best modality to differentiate between a solid versus a cystic breast lump, right? So to differentiate between a solid and a cystic lump, ultrasound is the most helpful. But the biggest drawback of an ultrasound is that it is operator dependent. So it is only as good as the ultrasonologist. This is a problem with ultrasound all over the body. It is operator dependent. Okay. Now coming to MRI. MRI of the breast, I'm going to tell you 6 indications which are extremely important from the point of view of your curriculum and the exams, and some of them have been asked in the exams as well. So the uses of MRI, number 1, I want you to remember that this is the imaging of choice in patients with breast implants. In patients with breast implants, this is the imaging of choice. And here I also want you to remember Linguini's sign, which is a sign of intracapsular rupture of implant. It is a sign of intracapsular rupture of implant. Next, MRI is the best investigation to identify multifocal and multicentric breast lesions, right? So multifocal is when you have more than one lesion in the same quadrant of the breast. That is a multifocal lesion. Whereas if you have lesions in separate quadrants, it becomes multicentric. And where is this useful? We are going to talk about breast conservation surgery later on. And in breast conservation surgery, if you have a multicentric lesion, it's an absolute contraindication for breast conservation surgery. So that is where MRI plays a role. So we've discussed the two indications. The third one, which I want you to remember, to look for chest wall recurrence or scar recurrence after surgery. MRI is a useful tool. The fourth indication is that it is a sensitive test for DCIS, right? I'm not saying this is the best test. I'm just saying it is a sensitive test for DCIS. The fifth indication for a breast MRI, if you have a patient with a suspected ductal lesion, if there is a suspected ductal lesion like a papilloma and ultrasound is normal or inconclusive, then we will do an MRI. Then we'll get an MRI done. This was asked in the AIIMS exam as well a couple of years back. So these are some of the indications to get a breast MRI done, and you should remember these for the exam. So we've spoken about the radiological tests. Now moving on to the histopathological tests. So in the histopathological tests, I told you about FNAC. Now FNAC, as you know, is fine needle aspiration cytology. Fine needle aspiration cytology. So this is a cytological test. It is not a histopathological test, right? You're not getting tissue, you're only getting cells. In the exam, they've asked that a 22 to a 30 gauge needle can be used for FNAC. The problem of FNAC when it comes to breast lesions, there are two main problems. A, it cannot differentiate between an in situ and an invasive cancer because we cannot document basement membrane invasion. Okay, that's number one. And number two, you cannot effectively study the ER, PR and HER2/neu receptors on an FNAC slide. So these are the two drawbacks of an FNAC, which is why the investigation of choice in a breast lump is a core needle or a true cut biopsy. So a core needle or a true cut biopsy, this is what a core needle or a true cut biopsy gun looks like, right? And if we talk about breast lesions, the best size for a true cut or a core needle biopsy for breast lesions is 16 gauge. But if you ask about the range for true cut guns, it can range from anywhere between 8 to 18 gauge. But for breast, best size is 16 gauge. The third is excisional biopsy. Excisional biopsy is when you remove the entire thing, entire lump. The first one which I told you and the second one which I told you were types of incisional, or you were just taking a small portion. You weren't removing the entire thing. Excisional is when you remove the entire thing. So this is the gold standard when it comes to breast lesions, right? So again, I want to clarify one point here. What is the difference between investigation of choice and gold standard? Well, gold standard is one which is going to give you the diagnosis 100% times, but it might not be the most feasible test to do. So imagine a 35-year-old patient who comes to me with a BIRADS 4B lesion, right? Now this patient has come to me. If I do an excisional biopsy straight away, I will get the diagnosis. Supposing the diagnosis comes out as breast cancer, right? So I'll need to go again and operate her. So the patient has landed up with 2 surgeries. Whereas if I would have done a true cut biopsy, I could have planned the surgery better, planned the incision better, and it would have been finished in a single surgery. Which is why the investigation of choice is a true cut biopsy, whereas the gold standard whenever there is a doubt is an excisional biopsy. So this was regarding triple assessment for a lesion, a breast lesion, and this is the order which you should follow for the exam as well.